Good morning, everyone. Welcome to the session on glaucoma suspect. As we all know, in the field of glaucoma, overdiagnosis and underdiagnosis go hand in hand. We always talk about the underdiagnosed patients, but we do see in our clinics many patients who are overdiagnosed and are medicines unnecessarily. So this session intends to give you an idea of how to diagnose a case and start treatment, whether to start treatment or not. So we have eminent faculties here for the session. First of all, I welcome Dr. Satyan. I know he doesn't need a formal introduction to this august guest. He is a director of Dr. Satyan's Eye Hospital, Coimbatore, Glaucoma Foundation. He has held many positions both in the international and national front, both in glaucoma and cataract. So he is accepted to give us the keynote address today. He'll be speaking on OCT and ERG in glaucoma. Over to you, sir.
Very good morning once again. And I would like to thank you for KSOS, Team KSOS, and also Dr. Bindu for this wonderful opportunity. This is my almost like a second home is Calicut. Thank you, Bindu, for the invitation. I'll just cover up both the topics as Dr. Sartha could not make it. I'll just see how much I can make an impression. When we are looking at glaucoma, basically we are looking at the cells which are probably is going to die, and we are looking at the cells which are going to, already dead cells. So I'll just talk about the ERG, where we are going to look at the cells which are dying, we are going to pick up and then see how we can really manage. The OCT really picks up those cells which are already dead. So that's why I put the topic as the dying and the dead. So I'm Dr. Satyan. Let's talk about the role of ERG in the glaucoma practice. Basically, the ERG is very useful in glaucoma suspects and ocular hypertensives, where we are looking at it is going to convert it to the open angle glaucoma. So when we really look at the glaucoma perspective, we have the objective and the subjective assessment of the optic nerve head by looking at the structural and functional capacities. One is by looking at the fundus photographs, where we really don't see the inner layers, we just see only the outer part of it. And functionally we use the octopus or the visual fields assessment by various different machines. But what we would like to have is the objective assessment, either by optical coherence tomography or by looking at the objective measurement of the functional capacity by the ERG. That's very useful. So the pattern ERG plays a very critical role. The ERG is nothing but the electrical response which is being recorded from the eye in response to the stimulation of the retina using the temporally modulating contrast gratings. So that's what we are looking at. Something like a time domain OCT and the frequency domain OCTs, we do have something in the ERG also, like a time domain and the frequency domain. So you see here there are two different wave patterns. Many of you, if you have used a ERG, you would have seen the first one, the transient wave. That's what we regularly see. There is a temporal rates which is being reflected is less than 6 patterns in a second. But when you look at the steady state, that's what we use currently, is more than 15 to 16 pattern reversals. That's where the wave pattern is completely different. So this is what we currently use. The ERGs are pretty useful in the glaucomas and the retinopathies. Earlier days we are just, okay, is it an RP? Just to diagnose that, or it is a confirmation that we used to do. But now we are using this ERG for a different purpose, to pick up the early glaucomas. So this system is called as a light-induced visual response system, which is pretty easy to use it. It is a non-invasive and has its own color codings. All the three machines are the same. It is only how the package is given to you. Each clinic can have their own way of having it done, depending upon the space available. So the pattern ERG really helps in the early diagnosis, like it can even pick up much earlier than your OCT can pick up. We used to say the pre-perimetric glaucoma. We can say now it is pre-OCT glaucoma, how early we can pick it up. So the AAO has mentioned it as, for diagnosis of early glaucoma, the ERG may be even more helpful than the OCT per se. So these are the how the chart will appear to be, the healthy chart, a dysfunctional chart, and like similar to the or OCT or other things, you have the progression analysis as well. So the trend plots. So healthy one, you can see that there is a wave pattern, there is a sine wave pattern of 3 spikes we can see. So if it is not the same as it appears here, then you can say there is a dysfunction is going on. Of course, it is much more than that what we need to understand. I will just go through that. Looking at the trend plot, it shows us over a period of time how the disease is progressing or improving. This is where we are going to see the improvement in the trend plot, not like the OCT or the visual fields where we see only the declining. In this we see the making it better also. Normally the treatment pattern, if you really look at in the current glaucoma assessment, once you start seeing there is a change in the OCT, that is the earliest sign which we can pick up, then we probably start treating the ocular hypertensives or the glaucoma suspects. But once you have the pattern ERG, what you can really do is the moment you see the pattern ERG change, that is where the cells are really under the stress. You start treating, then you start seeing the reversal of the disease as such. So you are not going to see any anatomical change in the OCT or the functional change in your visual fields. So that is what we are currently looking at. So can we make a change in our glaucoma patients? We keep talking about, okay, early change, what is going to happen? Nothing is going to happen. That's what we think. But only seeing eye, why do you allow them to go for a damage is the matter of understanding. So can variability in the pattern ERG signal help to detect the retinal ganglion cell dysfunction in glaucoma patients? Yes, absolutely yes. When you start seeing the variability, that is where you start really treating these patients, not to go for the glaucoma progression. So when you really look at the ocular hypertension, converting it into glaucoma, how much is useful in each investigation when you really look at it? The visual fields has a very less role, like 25 to 50% is the sensitivity in comparison to OCT, which has about 70%. The pattern ERG scores much higher. It is close to about 80% now, even more than 80% today with the upgraded versions. So let's understand a little bit about the pattern ERG. There are similar to other OCT or your visual fields, you have multiple zones. You have 4 different zones to understand. The zone 1 you have is the demographic information, you have the testing time and date, then you have the signal quality. Again, it is going to be extremely important to understand the signal quality in these patients. So coming to the zone 2, this is the steady state pattern ERG waveform. You have the sine waves, you can see that this is a typical 3-wave pattern. You have a 100% contrast sensitivity amplitude, and the other zone is you have the 85% contrast sensitivity. Is very crucial for glaucoma patients. You see this, there is an amplitude which is measured in the vertical axis as a microvolts, and time is in the horizontal axis is measured as a milliseconds. Coming to the zone 3, again you have the something called as a strip chart. The strip chart is very important to understand the artifacts, something similar to our false negatives and false positives. Once you see the strip chart shows lot of artifacts. This is a normal, you can see the artifacts is 0, and you can see that the strip chart shows multiple upshoots and the downshoots, and you have seen that 4. That means the it is not good. So you just kind of discard it. Then coming to the next area is the signal to noise ratio, that is called as the frequency distribution curve. You see there is a zone which I have marked it as a 15 hertz. 15 hertz is critical. You see that upshoot. If you don't see that upshoot, and if you see this deviation is more towards the right side, where the signal to noise ratio is pretty low, then again these charts are not to be considered. You see here the SNR is pretty high, it's about 10.6, it's quite good, and you see in the bottom chart the SNR is only 0.9, that's absolutely low. So that means either your mobile phone is ringing in there next to the area of testing, or there are a lot of electrical connectivities going on where your signal to noise ratio is so high, whatever you do is not going to be useful enough. Next area is the data table, which is a very critical zone. You see all green, everything appears to be normal. Once you start seeing the the yellow signal and the red flag, that means there is something is going on. It doesn't mean that it is abnormal. It could be abnormal or it could be just some kind of an artifact which is going on. So each area, if you see, what is the magnitude? So the first zone is the magnitude. Magnitude is nothing but the strength of the signal of the visual stimulus which is given to the patient. And the next area is the magnitude and phase variability. I'm just going to continue the other topic also, right? Yeah. So the magnitude, you see this particular chart here. When you give a signal, this is a one signal, then you can see one amplitude. Then you have given a multiple, the stimulus, then you see how the stimulus is giving the response. So this is called as a magnitude D. And you can see the ratio, magnitude D versus the magnitude ratio, that is the third zone. If this zone gives you, you see this 0 to 1 is the value, lesser the value, that is you can see it is 0.9. If it is going below 0.7, that means there is something is going on. So you have to be very careful about this. If it is below 7, that means there is a pathological changes are happening. So coming to the end of it, I am not going to discuss in multiple cases, but I'll just give you all 4 zones you understand and try to read this chart to understand whether the patient is having a damage or not. That is the first thing. Then you see the trend plot to understand how the trend is and then start treating or not to treat these patients. So that's how you read the ERG chart. So I'm just not going to the details of multiple patients. I'll just go to show only one patient. This patient showed a very early change in the visual fields, and OCT also has not showed much of a change, but then this has picked up. The IOP was 24 and 25. The ERG has picked up, showing the change in the wave pattern. So the patient was treated with the SLT, and you can see the wave is reversal of the pattern ERG waves. So this is pretty useful in these kind of cases. So Bindu, you have something to ask, or you want me to proceed with the next topic?
We have the discussion towards the end.
Okay. So I'll just give a small 10 seconds break, and then we'll go to the next topic because. Coming to the OCT, which we all routinely use. Some of you might have been there yesterday. I'm kind of obsessed using the softwares in your own systems on your consultation rooms. As I mentioned earlier, please start using your software rather than using only those printouts. As we get older and older, when I start seeing the printouts, I can't see anything in that, because there is absolutely no meaning to see the printouts because we don't know how the test is being done. Unless you start using your software, every company gives the software to access in your own systems. Please do ask the companies to provide you the software. You have the short access in your desktops. Please access and see each area of the 360 of your optic nerve or the macula or whatever you have, including your visual fields. That is the only way where you can improve yourself to understand what is going on. The moment the patient gives you the file to me, I say, please keep it there. There is no point in me reading those files because we don't know how the test is being done at all. So coming to the OCT, I'll just start showing you how you will start feeling it. Okay. So there are a lot of changes in the OCT than what we are used to. There is new changes in the optic nerve head, and there is a lot of changes in the posterior pole analysis. That is the GCL pattern, how we can really look at it. So when you're really looking at the optic nerve head, so there are a lot of new concepts, mainly looking at what is the actual anatomical area, or what you call it as the true disc margin, or what is the boundary of the disc boundary. So what we regularly see, you can see the green line, the vertical green line, that is what we really look at in our ophthalmoscope or your 90D or whatever you call it as. So that is clinically the inner edge of the scleral ring is the disc margin, and we take it for consideration to assess how much is the cupping according to that size of the disc. So this is the sclera which we are really looking at. But what we are talking at is the red line, the red vertical line, that is called as the Brooks membrane opening. That is what we call it as the possibly the true disc margin. So why it is important, you can see here the green and the red. The red is the Brooks membrane opening and the green is the clinical disc margin. There is so much of a variability in assessing what actually is the disc size. So once you look at that, then we will understand how much of an error all these years that we are making. Are we calling this as a glaucoma or are we calling this as a non-glaucoma? Once you see that in the pictures, the red zones and the green zones in the OCT, then you will understand why we have to go with the BMO as a true disc margin. Okay, there are many different studies to show that why we really need a Brooks membrane opening as a true disc margin, because since the blood vessels and axons cannot pass through the Brooks membrane, that is supposed to be called as a true structural boundary of the optic disc. So just look at the Brooks membrane. You see in relevance to the histology, Brooks membrane is here and then you can see the RP is here, but you see that how much of a reflectance it has, the Brooks membrane has in comparison to the RPE. More than RPE, the Brooks membrane has even more higher reflectance. But if you really see the thickness, the Brooks membrane is much thinner. You can see that it's about 2 to 5 microns in comparison to about 14 microns of the RPE. But then if you really see that, it is much more thicker because of its high reflectance in nature. So that's what the Brooks membrane is all about. I mentioned earlier the reflectance is the reason. When you really look at the OCT, it does about, the spectralis I'm talking about here is, it takes about 24 scan lines. Just to mention a few tips. In medical colleges where you have your OCTs, please ask for an upgrade in your OCT because your software may not have the GMPE software, those installed 5-6 years ago. But please do ask the company to give you that GMPE software, which is the most useful one. So it scans about 24 scan lines and detects about 48 BMO points. This is the BMO, how you have to see the Brooks membrane opening. It is basically, the machine gives you all these 12 quadrants to understand whether the BMO is marked or not. If you feel that BMO is not identified properly, you go back and identify the proper area of the BMO and then do the marking, and then you take the reading. That is the only way you can do it. Otherwise, whatever you read from the chart or your printout is absolutely useless. So first is go and see the BMO is marked properly, and then only you should see the remaining part of it. So the next concept is something called as a Brooks membrane opening minimum rim width, that is BMO MRW. That is the smallest distance between, you see here, that is the smallest distance between the Brooks membrane opening and the internal limiting membrane. This is again very critical because there are again, you can see here, some of the OCTs give you the BMO HRW, probably the Topcon and Zeiss, I don't know about the Zeiss much. The Topcon gives you the HRW, the BMO MRW is given by the spectralis. The reason is there are multiple studies again to show the value of MRW is much superior to the HRW, the horizontal rim width versus the minimum rim width. The minimum rim width always goes hand in hand with the thickness of your retinal nerve fiber layer, and it has a very good correlation. That's why the MRW has a much higher value than your HRW. There is another concept again, when you see the large disc, you have a large cup. When you see a small disc, you have a small cup. It is mainly the circumference which makes all the difference. Again, it has a lot of relevance when you are looking at the OCT. The larger disc, you have a larger the circumference. The bundle arrangements, the nerve fiber bundle arrangements are very loose actually. And it is little thinner than the small disc, which is very crowded. You see here, it's a large one and a small one. And I want you to see here, there is this concept of micropapillae and the macropapillae. You will have to just, this is 20 minutes? Or,
yeah, 20 minutes.
Okay. Okay, this will give a little. So micropapillae and a macropapillae. When you look at the BMO opening and then it gives you the disc size. Whichever is less than 2 micron size, that is called as a micropapillae. More than 3 is a macropapillae. Okay? So if you see this micropapillae, it is in the top of the line, in the green zone. The micropapillae patient, when they have this top line in the bottom, that means there is a really something is going on for them. It is not normal, even though it is in the normal zone, but still the patient is having a disease. So normal does not mean normal. Abnormal does not mean it is abnormal. So you have to understand again that concept. When the patient is having a macropapillae, and if it is shifted up, that means that probably the patient again has a problem. And if it is shifted down, of course, obviously there is a problem. And there is a 3-zone concept, again, something called as a alpha zone, then again a beta zone. These are the 2 zones we regularly teach all the postgraduates or the fellows. But there is a zone called gamma zone also. So what is alpha zone? You have the Brooks membrane and the irregular RPE. Here you can see this is the alpha zone. The RPE is still present, but in beta zone the RPE is disappearing here, and then you see the gamma zone, both the RPE and the Brooks membrane both are kind of absent. So next area is the Brooks membrane opening, MRW. How do you really do the analysis? This is the chart which is given here. There is a black line. This is to show which is the normal zone. And I have mentioned about the micropapillae and the macropapillae. You could have understood that. And when you start seeing the green line above this or below this within the green zone is the current, whatever the examination you have done, that gives you the details. And the gray line gives you the follow-up details. So this is how you start seeing that. This is the classification chart. It is little different from other OCTs. This does not give you the percentage of what it is. It is all in the percentiles. It is not the percentage. Percentiles gives you much higher prognostic values than the percentages. So if it is within the green zone, you can say that it is above the 5th percentile, and it is in yellow 1 to 5, and below is less than 1 percentile. So that gives a lot of values. And looking at the same way, NFL, RNFL also, you start seeing these zones. You see these dark shadows, that is all blood vessels. If you don't see the blood vessels, if you see the blood vessels and you see those areas, if it is not marked properly, again that is absolutely a flaw of the machine. Especially when you have a large blood vessels here. Some of them are having a little large blood vessels or a Torchworth blood vessels. Those gives you absolutely wrong values. So you have to be careful when you are looking at the chart, and you have to read this chart again. So please see those charts before you understand what is going on. Again, you have a 10-zone area in a OCT. I'm talking about the spectralis OCT. Of course, each OCT has its own different versions. So that's about the optic disc, the MRW and the RNFL patterns. And looking at the posterior pole asymmetry, this is one of the critical analyses that we have to make. This is how the sequence is arranged. Of glaucomatous changes occurs, the neuroretinal change, NRR changes should show up first, and then comes the RNFL and the ganglion cell. So when you look at the ganglion cell complex, what does this comprise of? This is the retinal nerve fiber layer, then you have the ganglion cell, and then you have the inner plexiform layer. Except for the spectralis, I am a big fan of spectralis, so that's why I keep mentioning about that, but I don't have any financials. The only OCT which can separate the GCL from the IPL is only the spectralis. All other OCTs, because of its nature, the mechanisms and the technology they have, it cannot separate the inner plexiform layer. But it is critical to have the GCL in isolation to understand what is really happening in that. So if you want to really see a change, that is the smallest measurable change which you can pick up in the spectralis is about 1 to 2 microns. The next best OCTs probably would be the Cirrus or the Optovi, where it can pick up the change at a rate of about 8 to 10 microns. That's pretty high. But when you really look at the values of the GCL, it is about 40 to 50 microns. The variability which you are talking about is close to 20% or even more. When you have a 20% of variability which is happening over there, that is not very good. What you need is a very, very close assessment to understand whether the disease is progressing in these patients or not progressing. That is a critical area which we are looking at. Looking at the next important area is something called as the fovea axis change. All of us, we know that the fovea is not exactly horizontal 0 degrees. Some patients have a +2 up, some patients have a -18 down. The fovea versus the center of the optic disc. That is how the nerve fiber layer arrangement pattern also. But if you consider every patient as having as a 0 axis, then whatever you are measuring is again absolutely wrong. That's what we currently do by looking at only those printouts. That's why, for God's sake, don't look at the printouts. Please go back and read from your own the machines, how the machine is giving you the details. So that is where the machine gives you something called as an anatomic positioning system, where it measures the center of the disc to the center of the macula, and then it forms an axis. That is what is called as a fovea BMO axis. That's very critical to understand how the pattern is. Always, almost 100% of the time, glaucoma will have an asymmetric representation between the upper half and the lower half. If it is symmetrical, what we are looking at is, we are not looking at the glaucoma, probably we are looking at something else other than glaucoma. So this is always asymmetry. So looking at the posterior pole asymmetry, this is very critical for us to understand. So posterior pole retinal map thickness you have, then again you have a GCL map thickness also. So you can see that the displays the retinal thickness over the entire posterior pole, that is a grid. The grid constitutes about 30 degrees versus 25 degrees of OCT scan volume for each eye. And the smaller grids are about 8 into 8 smaller grids. So that shows each area how much is the thickness. Once you start seeing 200 plus or 300 plus, that is actually the retinal thickness which we are measuring. It is not the GCL thickness. So how to really interpret the OCT asymmetry analysis? You see here the entire area which we can pick up, and it shows between the eye OD versus OS asymmetry, and also the superior versus the inferior. And it compares each eye, it compares the upper part and the lower half, and also you see the hemisphere asymmetry also it gives you. This is all the retinal thickness maps. Grossly you can see whether the retina is okay or not. But it is very important for you to understand, you have to see the retinal thickness in isolation, and also you just go back and click the other area, the GCL. Again you will see the GCL thickness map when you are really assessing the glaucoma in a very critical way. So you have the upper part, you have the lower part, and then you have the asymmetric between the eyes. So you see here the right eye and the left eye. This is the moment you see this kind of a thickness maps between the right, you see the thickness here, this is the GCL pattern, this is the GCL pattern here. This is called as the donut maps. The donut, if it is like this is fine. Once the donut gets cut off here, very typical of glaucomatous, this is called as a snail pattern. And you have the retinal nerve fiber layer maps. You can see a beautiful butterfly patterns. This is when you combine it, you can see the beautiful butterfly pattern. If you don't see these patterns, then you start understanding how much of the damage is happening in the retinal nerve fiber layer as well. So the ganglion cell map, as I mentioned earlier, this is a typical ganglion cell map. You have to understand the pattern, how it is. You see here again. And this is the overall, you can see the inner plexiform layers. The more the inner the layers you go, you start seeing how much of the vitamin deficiencies, especially the vitamin A deficiencies, how much the patient is having, especially the vitamin A deficiencies. Okay, so this is the typical pattern you start seeing here. This is the normal pattern of the GCL map. Then you start slowly seeing the disappearance, and you start seeing each area. Please go through and then see whether that is a true thickness, either it is increasing the thickness or the lowering of the thickness. That means there is a edema also can show higher thickness, but the patient may be having a GOA also. So you have to understand that. That's why I'm saying go back to your systems and understand. You see here how the vertical pattern is. This is a typical vertical pattern. When you see this is all non-glaucomatous. It's a typical hemispheric damages, hemianopic defects that you have to pick it up. And this is all kind of a AYN pattern. This is a AYN pattern. This is the glaucoma, non-glaucomatous pattern. This is a typical glaucomatous pattern. So you have the posterior pole analysis, the retina maps, you have the RNFL maps, you have the GCL maps. You have to really understand and correlate with the visual fields and the fundus photograph to understand whether the patient really has. And also it gives you the visual field assessment also. Then there is something called as a heat maps. We know that the gradations of the color in the color maps is not that good. That's why they have the heat maps. Many people in the European countries, they use only the heat maps because the gradations are much better in the heat maps than the color maps. So this is how you can see in the heat maps. You can just click on. So there is something called as a deviation maps. You see the RNFL deviation, how much it is here. You can see the deviations. And also the same way you have the GCL deviations also. The moment you see those deviation maps with the patterns, you can understand whether the patient has a toxic optic neuropathy, or is that patient has a glaucomatous change, or is that something else is going on. So this is very crucial for us to understand. These are all the Zeiss OCTs, and you have the top con OCT. There are different patterns, but you have to teach your staff at any cost. If you don't understand your OCT, or if you don't understand your ERG machine, please try to ask the companies to come back. Please read the manual. As an Indian, at least for me, we never have the habit of reading the manual. You open the cell phone box, connect it, call it, and talk. That's what we are used to. There's nothing to blame. But if you can read through the manual, probably you can teach the company so many things. And you will understand better. You will be in a much better books. So thank you so much for your patient listening. And I hope I have given you some message to take home to practice in your daily practice. Thank you so much, Bindu, for your the opportunity which is given to me. And thanks to Santa also that she couldn't come, so I could do this presentation. Thank you.
Thank you, sir. We are really thankful to you to take up the challenge, last minute topic also. And you rightly mentioned it is not just we have the newer investigation technique, how we do it and how we interpret it is more important. And that is what he beautifully explained to us. Thank you, sir. Thank you so much.
Next, I would like to call upon Dr. Pankaj Bindale. He's a glaucoma and cataract surgeon, currently working in National Institute of Ophthalmology, Pune. And he's going to talk on is the field reliable?
Yes. Yeah, first of all, I thank KSOS and I thank Bindu ma'am for inviting and making me a part in this IC. So after a very, very ideal talk where we can pick up a very early glaucoma suspect with very good evidence through the machine, I think now let's come to a practical talk, because everybody doesn't have a luxury to have that kind of machines where you will have a fovea BMO axis or posterior pole analysis. So that's a luxury, because why all this logic is key, and as the IC says, glaucoma suspect, because all we are looking through our examination is find of solid evidence, whether to treat or not to treat, whether to observe. That's what Bindu ma'am said in initial introduction. So all that we do is key. We want a solid evidence to say whether this is a treatable case, whether this is really a glaucoma or this is a normal, whether we should treat or whether we should observe. So everybody has access to the perimetry, OCT, fundus photo and all. If they are there, then they are very ideal, because this is where OCT plays a very important role, where you want to separate the suspects from the treatable cases. So how the glaucoma suspicion starts clinically, because anywhere IOP is more than 21, again here I will say pachymetry is important, because some of the corneas are 600 micron, 590 micron, IOPs are taken on non-contact tonometers and pressures are on the higher side, and immediately glaucoma suspicion get raised. Shallow AC is seen on the clinical examination or suspicious disc, and that's where then the glaucoma workups comes in the picture. This I will focus on the diagram, because we all know as glaucoma evolves, in the middle part of the glaucoma, visual field, RNFL, everything will match with everyone. Like you will have a nice RNFL defect, you will have a nice perimetry corresponding to that, you will have RNFL analysis which is exactly matching with the RNFL defect on the disc photograph. So middle part of the glaucoma, advanced glaucoma, there is no confusion. Confusion is only in this initial portion here. Confusion is only in initial portion where we feel RNFL is available or not available. Disc photos as of not showing very clear RNFL defect. Perimetries which are expected to be normal at this stage, but they are still showing some haemorrhage scotomas. So whether they are reliable or not, should we trust them or not, and on that, whether we should take the call to treat or not to treat. Again, as far as reliability data concerns, we know that there are again few of the errors in the acquisition, and I will feel, as sir was saying, first of all, know your machines well. Perimetry is not just you ask patient to do a perimetry, perimetry does perimetry and they give you a printout to consultant, because we know a lot of things goes in between, lot of errors happens, there are a lot of acquisition errors. That's where I will say almost 30-40% perimetries, you have to just keep it aside before taking any final call or whether to treat or not to treat. So there are various factors that affect the perimetries. There are some patient response factors, whether you have informed the patients properly or not, how is patient's reaction time, he's doing it first time, his cooperation level after waiting for a long time in the OPD, then suddenly you are advising the test and asking him to do quickly the test. There are some of the clinical factors like pupil size, whether patient is able to maintain the fixation properly or not, whether target is blurred or not, any media opacities, age, trial lens frame, whether it is properly put or not, ptosis. And there are some of the factors which are machine factors like fixation monitorings, because like Octopus, as sir was talking about, Octopus has a very good feature. As soon as patient moves the fixation, it doesn't show the next stimuli. So whenever he again maintains the fixation, then it again gives a stimulus to the patient. So that's very, very good, because then you don't have much of errors. If you see Humphreys or if you see other machines which can just give you the fixation, other monitoring, other thing, and few of the other perimetries, they don't have anything called fixation monitor. So they just start the test, they just finish the test. Even if patient just press for 1 or 2 times and then moves out of that machine, test will have its own time of 5 minutes and then will show the printout. So fixation monitor in your perimetries is more important. Test retest reliability. Some of the machines, they don't have that much of test retest variability. You do a test now and you do tomorrow, still there will be some variability. That doesn't mean glaucoma is changing within 1 day. How is the program designed? Ability to recognize the patient's unsteady fixation is very important. And if that is not there in that machine, then that value of that printout really goes down. Another very important area which is very often neglected is perimetry compensation lenses. What lens you want to keep in that machine when patient is doing the perimetry? Because the tasks are near. Patient are doing the test with progressive glasses, patient doing glasses perimetry with bifocal. There's something, all that can add the variables and all that can add artifacts to the perimetry. So ideally, if you are using a right compensation lens and then seeing that there is no any rim artifact and all, then that is a more ideal perimetry effect. Now here it was a patient having a 21-22 IOP. When I advised Octopus perimetry, this is where the defects were there. This is for the left eye, and this is for the right eye. So 0.6 this immediately, if someone is not having a backup of the other machines, then sometimes they are labeled as a primary open angle glaucoma, labeled as some few paracentral scotomas. So I feel whenever we are advising perimetry, we should already anticipate the scotomas. If you are having a lower rim is slightly thin, you expect something coming superiorly. If rim is getting thinned out, then expect something inferiorly. If something doesn't match to your clinical expectation, I think again the perimetry, that is not the reliable one. If you have any doubt, again repeat the perimetry. Sometimes we have a tendency to come to conclusion only on the basis of one perimetry, and that is sometimes a trick there. Patient has his own learning curve. First time he's doing some subjective test, and that is prone for error. So something is outlier, something doesn't fit into as per your expectation. I don't mind calling patient again and doing the next perimetry. So this was the patients where IOPs were consistently high. When we did a pachymetry, it was 594 and 603. And then again, what helped me for decision making was the OCT. When I advised the OCT for that 0.6, 0.7 cup, OCT was still within the normal limits, and other eye also within the normal limits. So this is where I feel now, whenever you are having a very doubt about the glaucoma suspicious cases, simple perimetry disc photos are not sufficient. You should have either some more access to the OCT or this GCC study, ganglion complex studies, and plus if you have some of the other very latest machine, as Satyan sir was saying, plus ERG and all. I think this is where we can differentiate the cases where we should treat and where we can still observe. Whatever said and done, I think routine follow-up, routine observation, reviewing your diagnosis again after 6 months is the ideal thing, but don't jump to the conclusion and start the management immediately, because then that goes on the over treatment, and patient also then is a lifelong glaucoma patients, and their relatives also become a patient with a known history of glaucoma. So few pearls if I offer, if perimetry is not correlating with your disc finding, repeat the perimetry again. Know your machine very well, know all sources of error in your machine, supplement with disc photo, and then you can nicely compare that where the disc is thin, where the RNFL is thin, and what effect they have come on the perimetry, whether they are really matching or not. Only perimetry cannot drive the diagnosis in glaucoma suspicious cases. Only perimetry is good for middle glaucoma when there is a definite notch and other very definite clinical signs of glaucoma. But when you are treating suspicious cases, I think you need one more solid evidence. So check the repeatability of the scotoma in same area, check its correlation with the disc changes. At early stage, correlate the defect with the RNFL analysis to add value to your clinical decision, and understand the limitation of this test with the potential sources of error. Try to yield more valuable information by correlating all clinically available information and take better decision for your patients. But as madam was saying, introduction of IC, don't overtreat. There is no problem that you review your diagnosis again after 6 months, again after 1 year. Follow-up is more important. Starting the treatment at the earliest suspicion is a very easy thing, but waiting patiently and treating only when they need treatment, I think that's the best justice to the patient disposal, rather than just treating on a very shoddy or very shabby workup. Then that's not right justice to the glaucoma suspicious cases. And whenever you need, investigate further for clear evidence with the OCT or some other newer investigations, and that will give you a solid evidence to treat or not to treat. Thank you.
Thank you, Dr. Pankaj, for the excellent talk on visual fields and putting into perspective the different factors affecting the perimetry.
Next, there is a panel discussion on walking through cases of glaucoma suspects by Dr. Bindu S Ajith. Madam is the HOD of glaucoma at Compressed Eye Hospital. Over to you, madam.
So when we have the dawns of glaucoma here, I thought we're always facing dilemmas and situations where we can't take decisions in our OPD. These are the scenarios which we daily face. So I thought we'll just discuss and have opinion from them. So this was a case, a myopic male medical student with a family history of glaucoma. He's a 23-year-old boy, and his IOP is 18 and 20. Her facing was done, which is negative, and the central corneal thickness was 527 and 532. And this was the fundus picture, I think sir can see. So now, how do we go about this case, sir? A family history of glaucoma with an additional risk factor of myopia and an intraocular pressure of 20. This is a situation we daily face in our OPD.
Yeah, first thing is taking the fundus photographs and comparing it in your desktop. See the fundus photograph, both the right eye and left eye together, so that you can understand better about the disc size and the shape of the disc. So many patients will have very typical, there are three different patterns you have. One is the circular one, then one is a horizontal pattern, and then you have the pear-shaped disc. These are the three commonly seen disc sizes. The moment you see the pear-shaped disc, then you will have an understanding that the cupping will be according to the pear shape. So you might think that the patient has an inferior notch and then go on having confusion. But in this case, you can see that there is, looking like at least, there is a reasonable amount of an asymmetry, but the disc size, I mean the shape of the disc is quite round. There's a central cupping, but when you have the central cupping in an younger age group, there's always an enlargement happens in the only circumferentially. It doesn't happen like in the adult patients where you have inferior notch or superior notch. The younger ones will have from center to periphery, it goes smoothly. So it is very difficult to say this patient is not having glaucoma.
Yeah, this is the OCT picture.
Yeah. The OCT, you can see this is the spectralis again. Yeah. You can see the right eye, the OD, you can see there's a lot of red areas, but as I'm becoming older, I'm not able to see the numbers. But there is a lot of red zones, but it looks like more of a nasal red zones. The nasal red zones doesn't mean anything to me, but it has to be both the superior temporal and the inferior temporal has to be very specific. You can see the inferior temporal, there is one, the RNFL shows a change, but the MRW shows the overall thinning in the right eye in comparison to the left eye. Left eye also you can see there is an overall thinning, but the RNFL pattern, if you see the right and left eye, there is a specific area. The inferior RNFL seems to have a bit of a thinning. But you go to the asymmetric map, again, the bottom, the asymmetric map, the GCL map, it is basically the GCL map. There's overall thinning in the right eye, more so in the, I won't say more so, but there's a bit of a thinning in the right more than the left eye.
So this is the field of the patient.
Fields in these patients has absolutely no value.
So do we subject these patients
and
to
you
PRG?
You see the right eye, you see the bottom of the graph, how much of upshoots the patient has. So
This is the repeat fields, sir.
Okay, the repeat fields again, it is all the edge points.
Yeah.
Is it 24-2 or?
24-2.
Even though it is 24-2, it is all in the edge points. But if you see comparison with the disc, and if you see these edge points, I have no value for the visual fields in this. The OCT shows, but again, it is not a typical changes of the glaucomatous change. But a 24 years old having so much of a thinning in the MRW needs probably a further investigations rather
Does
than for
ERG have a role in these cases?
Absolutely yes. Definitely yes. So the ERG definitely plays a role. But the way it appears, it is not a very typical of glaucomatous at all.
Thank you, sir.
Pankaj, you want?
I will add that we should have again the guts to know keep all red OCT also aside. If clinically if you feel it is not treatable as of now, observe. Even if it is a red, that doesn't mean that OCT machine knows more than you. No, you are the one who take final call. So as sir said, as of not convincing about glaucoma, observe. Yes, yes.
Okay. So this is...
One is observe, other is try to investigate why. Other reasons, yeah.
If you have access to the best
Yeah.
So this is another scenario which we face, a patient coming for some other reason, but the routine NCT picks up an IOP high, and then they are referred to the glaucoma department. How do you go about it?
See, PACI is on 578, so it is really on higher side. So I don't go by very value-added correction, this much correction factor, but I decide the PACI into thick, thin, normal. Here it is definitely a thick PACI, and one thing I will add, thick PACI is, NCT is more erroneous. If the 80 shows higher reading, NCT reading can be haywire up to 26. But I feel discs are very healthy, RNFL is very healthy, so ultimately we are treating the optic disc or saving the optic disc. If disc is not showing anything, if IOP 23, 24, probably these are the normal IOPs for these eyes. I will serially follow and I will wait for the any solid evidence before saying you need lifelong treatment.
Coming back to the CCT values, how many of you really want to see the CCT and treat? Okay, at least some hands are rising up. I want you to understand one important concept is, once you have a higher CCT, it does not mean the patient has a normal eyes. Say for example, IOP is like 24 and CCT is high. You just don't discard those IOP values as 18 or 17. It doesn't mean that way. That's an important concept I want you to understand. The patient has a higher IOP values, definitely yes. But then when you have the higher CCT values, these patients going in for the next stage of the disease is they have a higher immunity. They have a better tolerance. The progression to the next stage of the disease is much lesser in comparison to those who have a normal CCT values or the lesser CCT values. Please don't take it as 24 to 18 and then I will not treat. That's not the way you do things. So that's the concept which I wanted to communicate. Any of the corneal properties has a value, but then the corneal hysteresis, we all became hysteric at one point in time, but now none of us talk about the corneal hysteresis as much as what we were discussing earlier days. Once you have a very established glaucoma, you have no value for any of the CCT values. The patient has already developed the disease. Now you better treat the disease how you want to really treat it than looking at the CCT values.
I think that's what OST study was not having pachymetry, that came later. So some of the properties we might be still not knowing. But as sir said, once it is established glaucoma, keep the pachy aside. But one of the immunity we were saying now, it is a surrogate marker for lamina cribrosa thickness also, because same CCT, same higher clearal thickness, same kind of lamina cribrosa. Somehow thick cornea is a very well resistant to glaucoma damage indirectly by having a good lamina cribrosa was the people's assessment.
But being better immunity doesn't mean that we don't start the treatment.
Start treatment as per the risk profile. At
Yeah,
20 years,
exactly.
20 to 24, ciliary followed, disc is remaining healthy. At earliest RNFL defect or some definite sign, definitely I will treat. But till that, I will pause.
Now we'll go to the next case scenario. A 43-year-old female who was referred for glaucoma evaluation. And then how often, I'll just like Pankaj to tell about the field here.
Yes, no, see, there are, once you keep two field as, like side by side, no? Actually, you should have kept right here and left on this side, then you just know very well bitemporal hemianopia. But whenever you see this kind of thing, BCVA going down, temporal pallor, some mild color vision defects, suspect chiasmal pathology, and that's what is the thing. Now, in addition to that bitemporal, why that defect on this side, that's the one confusion where I would like to repeat it once again.
Actually, the patient also had amenorrhea and had a pituitary adenoma.
Pathology.
Yeah.
Yeah, but again, can you come back to the perimetry? Again, this why that right side perimetry was having effects prior to that side. I think this is where the learning defects are. So I feel if the perimetry is repeated, that some of the scotomas on the other side should disappear.
Disappear, or when you have a pituitary apoplexy,
Yeah.
it might show something like this.
Yeah, but central sparing, but yes, if they are repeatable, then give value. So bottom line is anything that is repeatable adds value to that scotoma. Yes.
Okay. This is a situation where you have prominent vessels, and of late we have seen all thyroid patients with prominent vessels, and but when two of our patients had indirect CCF, we don't know the.
This is quite common to see. It's not very abnormal to see that AV malformations. Anybody below the age of 40 or 50 years, and then you have only one eye, there is a sure cause. Only thing is we don't know how to look for the cause, or we are missing it somewhere. But anybody above 50 years having this kind of things, it's kind of, we say it is more of an idiopathic things. But whenever we say idiopathic, we don't know. So that's the only thing. But anybody below 40 years, 50 years, you have to search for the cause.
Yeah.
Before we just blindly treat only the glaucoma. Whenever we are treating this, IOP we are treating, we are not treating the actual disease. Find out the cause, treat the cause, it will all disappear immediately.
So it
There's
need
no
not be
point.
always the florid picture of CCF.
See, many of the times, many of us do treat only the IOP as a disease, but it is not the true disease. We need to look at what kind of a pattern the patient has. Many people, they have a habit of going to the gym, the way they do the asanas, they do their breathing exercises, they do the water drinking. So there are a lot of things which we need to, sleep apneas, cardiac problems. There are so many other things which we really don't ask for, or we haven't understood that there is a cause for the progression of the disease. It is not only the compliance in glaucoma causes the progression. There are multifactorial reasons that we need to understand. So treat the patient in comprehensively, or a holistic approach to the glaucoma patient is much more important than just looking at the charts and saying, okay, you treat this. It's not the way you do.
So a picture like this, what are the things we have to see when you're taking an OCT? You're talking about the markers, like what will help us to do a better OCT in these patients?
I think here I will rely more on disc photographs, because anomalous disc, no, I will not give too much of value to the OCT. Not that I had one case of coloboma developing glaucoma. So things, rare two pathologies also can coexist. But I think here at the IOP, good disc photograph, that should be sufficient to see, and serially follow on the perimetry. Generally scotomas are static. If they are progressing, then only the diagnostic or treatment dilemmas will come in the picture. But otherwise, anomalous disc, I think OCTs are just like a useless paper, because they don't give you what you want out of that 2,000, 3,000 rupees test. No, they don't add to the value decision making.
I know.
I'm going to give a very controversial statement to what Pankaj just said. This is where the OCT has the highest value.
Yeah.
When you do this and then you assess the BMO points, understand what is the BMO areas, we are looking at the true disc margin, especially when you have the myopes. When you really look at the BMO points and understand what is the disc margin, you can really do a lot of wonders in the OCT. And also you can, because the GCL map and the RNFL map in myopics are having a very less value.
Always in myopia we are confused with
already
the
atrophic
diagnosis.
changes will be there. So this is where exactly the BMO points are going to be very critical. But what Pankaj is saying is, because he is using the TopCon OCT, though his boss has a spectralis, he is not using the boss's spectralis. I would recommend you strongly pull that, take it to your center, and then use your spectralis, so you can really find out. What I'm really wondering is, all the government hospitals, they do have their spectralis so beautiful. Only thing is, they have not upgraded your softwares. Please upgrade today itself. Go back, upgrade your software. You really start enjoying using it. You will be doing so much of new diagnosis of toxic optic neuropathies, especially in Kerala. I'm not going to say anything bad about Kerala. But when you have so much of an alcoholism, you pick up so much of toxic optic neuropathies when you see this, the typical pattern of papillomacular bundle getting affected. Even if you take one shot of local liquor, you will develop these toxic optic neuropathies. Many times we'll be wondering what is this? And B12 deficiencies, thyroid diseases, high homocystinemia, homocysteine levels, all these you can just pick up by doing the simple regular OCTs. You'll be able to really pick up all these. Fundus photographs, please do pick up these peripheral RNFL defects. Only way you can do is by looking at the fundus photographs, not by looking at your 90D with the 4 mm people or 3 mm people. You will not have stereopsis when you have only 3 mm people. You have anything beyond 4 mm only, you will have your stereopsis. But many of us, when you have a busy OPD, you will not be doing your, the stereopsis examination.
So just one interesting case is a 19-year-old girl who comes with recurrent episodes. She feels that her eye pressure is high, and then she has a discomfort in the eye, and always she has this KPs and intraocular pressure of 34 of intermittent attack. How do we go about it, sir? As a post-nurse man with intermittent, the disc and the fundus is normal, all other investigations done. She has this recurrent attack of IOP of 34. Yeah, like whenever she comes, is this the way to treat, or does she need only when there is an intermittent attack?
So, see, I think no, the recurrent attack will keeps coming. Every time you treat them with mild steroids and anti-glaucoma, every time you treat them sufficient steroids, again trabecular meshwork doesn't develop too much scarring, come back to normal. But I think with recurrent attacks, these eyes can become permanently glaucomatous. With few may need the chronic anti-glaucoma medication, or few might go towards the trap or Ahmed wall also surgeries, because these eyes, if they keep developing recurrently, we don't know the natural history, how much they will get, how many years they will keep getting it. But if whenever they get, we have to treat it, because as of, we know only that much about the PS syndrome. You can investigate for autoimmune disease, other things and all, but if you don't find anything, then treat with the working diagnosis. That's what will be my approach.
Yeah, typically PS syndromes, the recurrence is pretty less. Yearly once or twice, you treat only that 1 week or 10 days period. But as Pankaj was mentioning, once it becomes, recurrence is pretty high, then there is a permanent damage to the trabecular meshwork, and you start treating that as just other normal glaucomas. But only thing is, we really don't go for a regular therapy. You see the patient periodically, and then you can take a call.
I think we can go on and on, but for the time, I thank you all for joining our session. I thank the panelists, Dr. Sathin sir, Dr. Pankaj, and the chairperson and the co-chairperson, everyone. Thank you so much. I will just have a picture.
Yeah, thank you. Thank you, Bindu, for your wonderful, lot of cases, discussions. And I really want to thank our co-panelists as well, because they gave us a lot of opportunity to open our mouth.